Okay, cholinergic blocking drugs. So these are going to dry you up. Remember, these are technically on the adrenergic or sympathetic side, the fight or flight side of things. They have different names, right? Cholinergic blocking drugs are also called anticholinergics, cholinergic blockers, and then also parasympatholytics. That means they work against the parasympathetic nervous system. Okay, they're more sympathomimetic in nature. Actions. How do cholinergic blocking drugs work? Well, we know cholinergic drugs worked by increasing acetylcholine. So cholinergic blocking drugs work by decreasing acetylcholine. They block the action of acetylcholine at the receptor sites in the synapse, and that decreases that acetylcholine level. Some of these medications work on the nicotinic receptors, and some of them work on the muscarinic receptors. Nicotinic receptors are going to help with our skeletal muscle innervation, and muscarinic is going to help with smooth muscle. So these medications can either be receptor selective or non-selective and have systemic effects. Uses. Why do we use cholinergic blockers? Well, they dry patients up. So maybe they have ureteral or biliary colic. Maybe they have bladder overactivity. So if they're peeing a lot, or they have a lot of release of bile from their liver and gallbladder, this medication is going to dry them up, right? Maybe they have Parkinson's, and with Parkinson's, they have too much acetylcholine. So I might give them a cholinergic blocking drug in order to decrease their Parkinson type symptoms. Maybe they have pylospasm or peptic ulcer or IBS. I want to dry up some of that stomach acid and help decrease GI movement, right? Because usually these people, things are flying right through them. Potentially some vagal nerve induced bradycardia. And we know that if we are working against the parasympathetic side, that means we're going to increase the heart rate. And then we give atropine specifically to decrease pre-op secretion. So like spit and drool in the mouth, helps to dry that up so they don't aspirate it during surgery. So here are some other examples. We do have those systemic medications like atropine, helps with that pylospasm, biliary colic or ureteral colic. It helps to decrease secretions. And then we also can give atropine for bradycardia to increase the heart rate. Big important fact here, circle, star, highlight, whatever you do to remember that this is important. If the client cannot pee, already, or they have urinary retention already, should I give them atropine to dry them up? And the answer is no. No, I should not give them a dry you up medication, a cholinergic blocking drug, if they already have urinary retention. Atropine would not be a good choice for those patients. We also give dicyclamine, which is Bentyl for irritable bowel syndrome, glycopyrrolate for people who have peptic ulcers, to help to decrease secretions, to block that vagal reflex bradycardia, which causes the low heart rate. Okay, so glycopyrrolate and dicyclamine are two medications that we use a lot in the GI world to dry clients up. We like glycopyrrolate specifically for ulcers because it helps to dry up the hydrochloric acid that is in the stomach in order to allow the ulcer to heal, right? It's not like a hyperacidic or hyper secretory environment for them. Here's an important fact. Once again, circle, star, highlight, whatever you do. If we give the client glycopyrrolate, it's going to dry them up and they might have some serious adverse reactions or uncomfortable adverse reactions that we need to prioritize as an adverse reaction to the glycopyrrolate. So examples, if we dry up the mouth, we might end up with some dry mouth, moving down to the esophagus or the throat. If we dry up the esophagus, we might not be able to swallow food, right? So we might have some dysphagia. So dry mouth, dysphagia. Down to the stomach. Although it's a great environment for my peptic ulcers to heal, if I have food sitting on my stomach and no acid in there to break it up and break it down and move it on, I might have some nausea and upset stomach. right? And then down in my intestines, if they're dried up and their peristalsis is slowed, that means I'm not moving things along fast. And we want that to slow down a little bit when we give these medications for things like IBS, but completely slowing down can cause constipation. So again, too much glycopyrrolate or adverse effects of glycopyrrolate I need to be aware of: dry mouth, dysphagia, nausea, constipation. Okay. With scopolamine, I might give that for pre-anesthesia sedation or to help with motion sickness. Trimethobenzamide for nausea and vomiting. And then those are our systemic anticholinergics. Let's talk about our urinary antispasmodic anticholinergics. And these are used for overactive bladder, specifically those with spasms. Darafenicin, fesoterodine, oxybutynin is a big one, and tolterodine is another one. These are medications that will help reduce episodes of incontinence and running to the bathroom as well, right? Parkinson's disease. So we're going to learn more about anti-Parkinson drugs later, but in general, these are some of our anticholinergic or cholinergic drugs we use for Parkinson's. They help with not only the symptoms of the Parkinson's disease, but also with those extra pyramidal symptoms that can occur. Benztropine mesylate, diphenhydramine, which is just good old-fashioned Benadryl, and trihexyphenidyl. These are our Parkinson's disease cholinergic blockers. And then the last category are your respiratory cholinergic blockers, like aclidinium and ipratropium, which is an inhaler, right? And then tiotropium, also an inhaler. These help with bronchospasm. So if we know that our cholinergic drugs or our adrenergic blocking drugs are bad for people with asthma, it makes sense that these are good for people with asthma. They're going to help to dilate the bronchioles, right? Adverse reactions in the GI system, we talked about this: dry mouth, nausea, vomiting, difficulty swallowing, which can cause dysphagia, heartburn, constipation. And then our CNS system, we see headache, flushing, nervousness, drowsiness, maybe some weakness, insomnia, congestion, and fever. In the visual system, maybe some blurred vision, some pupil dilation, because we're working on that sympathetic side. Photophobia, which is sensitivity to light with our eyes. Cycloplegia, paralysis of the eye or inability to focus the eye, and then maybe some increased ocular tension as well. That's why these are probably not great for people with glaucoma. Genitourinary system, maybe some urinary hesitancy or retention, some difficulty urinating, dysuria. Cardiovascular, some increased heart rate, tachycardia, and some palpitations with that. And then that paradoxical effect of bradycardia in some occasions, situations. And then some other symptoms or adverse reactions to these medications: urticaria, rash, decreased sweat production, and potentially even anaphylactic shock. So that would be bad news bears. Older patients may experience excitement, agitation, confusion, and drowsiness, maybe even some urinary retention with small doses of these medications. If we notice that they are having some CNS changes or their output is going down, we need to hold the dose and tell the doctor. These medications are contraindicated in clients that are allergic to them. Well, obviously, right? Have glaucoma because of the increased ocular tension. Those clients that have myasthenia gravis because they already have too little acetylcholine, so I want to increase it, not decrease it. Clients who already are tachyarrhythmic or have a high heart rate. Clients who have recently had a heart attack or a myocardial infarction, and those clients in heart failure, unless they are bradycardic and I'm giving it to support the blood pressure. So this is kind of an important thing for you to know. You need to know that these types of patients, I would want to be careful giving a anticholinergic to. Okay, anticholinergic to. Okay. Use cautiously if my client has a GI infection, because I want to move along that infectious material. BPH or benign prostatic hypertrophy, and that's because they have a hard time using the restroom. Urinary retention, hyperthyroidism, hepatic, which is your liver and renal disease, kidney disease, right? Asthma and pregnancy. Interactions with antibiotics and antifungals. These can decrease the effectiveness of antibiotics and antifungals. With meperidine, flurazepam, and phenothiazines, that can actually increase the effect of this cholinergic blocker. So can tricyclic antidepressants. And then haloperidol mixed with these cholinergic blocking medications can cause decreased effectiveness of our haloperidol, which is a really important anti-psychotic medication. So we don't want to decrease the effectiveness of that drug. And then digoxin, we have the increased risk of digoxin toxicity when given with cholinergic blockers. Jumping into the last section, our ADPI. A is focus on ulcer management because other chapters will discuss other indications, right? Other reasons. We need to collect a thorough health assessment of our client and a history of their symptoms. We need to measure their baseline and ongoing vital signs. We need to be looking at their stool. What color is it? What's the consistency? Is there blood? If I have a glaucoma patient that's taking these cholinergic blocking medications, I need to determine their visual acuity. Can they see well? I need to be watching my client for signs and symptoms of dehydration and get a baseline and ongoing weights, especially if my client's been having diarrhea, because I want to see that improve. Diagnosis may include impaired comfort, constipation, risk for injury, and ineffective tissue perfusion. And obviously my plan or my goals are for an optimal therapeutic response to manage and prevent adverse effects and for my client to understand and comply with treatment. Implementation. So as the nurse, what are our interventions? Well, we need to give these medications at the exact time that they're ordered. For example, if it's a pre-op medication, I need to give it before surgery, right? And then before giving it, I should encourage my patient to void. That way I can collect accurate I's and O's moving forward and see how this medication impacts their urinary system. I need to explain to my patient that extreme dry mouth and drowsiness can occur 20 to 30 minutes after they get the medication, specifically atropine, right? If I'm giving it in pre-op, I also would want to raise the bed rails for the client and tell the client to stay in bed because you can get a little dizzy. Xerostomia or dry mouth comfort interventions, sips and chips, gum, lozenges, maybe a moistened mouth swab for clients with dry mouth. And then I need to be checking that mouth frequently for sores and ulcers. Increased fluid intake to 2,000 milliliters per day. And we want to increase the fiber and increase exercise to keep those bowels moving. Administering stool softeners as ordered will help move the bowels along, and increasing ambulation will as well. We want to encourage the client to wear sunglasses, and we want to darken the room because of the increased photophobia or light sensitivity. And then remember, our older clients are always going to be at increased risk for signs and symptoms of those adverse effects. One of those being heat prostration. And this is due to the decreased sweating. So they're not going to be cooling themselves off naturally. And we would want to discourage them from being outside on very hot days while they're taking these medications. Wear loose, light clothing, sponge the skin with some cold water, and make sure they're drinking a lot of water. And then lastly, we would want to watch the cardiac monitor for any rhythm change if we're giving it for a heart condition, right? They had like a bradycardia or bradyarrhythmia. We give the atropine, it increases their heart rate. And lastly, evaluation. We achieve the therapeutic effect. Those mucous membranes are moist, so they're not extremely dehydrated. They have adequate bowel movement, so they're not extremely constipated. There was no fall or injury. Their vision is intact and hasn't worsened. They've got good tissue perfusion, and they understood and complied with treatment. And that's a wrap for chapter 27. I will see you in the next chapter.